I sit alone in a sterile room under cold fluorescent lights, awaiting the results I was called in to hear. There's a soft knock at the door, and a woman in a white coat enters the room, confirming my name as she washes her hands at the pristine white sink. She introduces herself as Kira, a first-year medical student working with Dr. Amin, and she asks me if I know why I was called in today. I say, I assume it has something to do with my mammogram. And she says yes. There was evidence of a small lump in my left breast, and it required further testing and biopsy. I kept myself together. I had had time to prepare for this information. Then Kira says, there's something else you need to know. She tells me that the spot was first seen 2 years ago with my last mammogram, but because of a communication breakdown between the radiologist's office and the clinic, Dr. Amin never got that information. I can feel hot tears filling up my eyes, and I say, how does this even happen? 2 years ago, you told me everything was fine, and now you're telling me that this growth, this cancer has been allowed to grow for 2 years? Kira apologizes. She says, it is inexcusable what has happened, but she and Dr. Amin and everybody in the clinic was going to do everything they could to make things right. I looked Kira straight in the eye and I said, how do you make something like this right? Then a voice from the overhead speaker says, time's up, please begin your feedback. 7 minutes later, I sit in a sterile room under cold fluorescent lights, awaiting the results I was called in to hear. I think I was told I have cancer about 15 times that day. And that is my job. I am a standardized patient. And now, before we get going here, I do have to make a disclaimer. Per HIPAA laws, these are information privacy laws, I cannot tell you any specifics about a patient's case or about a student-doctor interaction. For example, ma'am, what is your name? Amy. Thank you, Amy. I cannot tell you about the specific time that Amy went in to see her doctor, sneezed, and accidentally shat the exam table. That is very private information. Yes. And there is genuine concern that should somebody learn about this incident, they might turn to use it against Amy. So, and honestly, what's important is not the specific time that Amy schnarked the table. What's important is that we all know that at some time someone has table schnarked. And that's what's interesting is the journey from, oh my goodness, what is this feeling, to, oh dear Lord, I just snarked myself. So through the duration of this presentation, all names and situational details have been changed to protect people's privacy. Do we all understand this?
Yeah.
Okay. Please put your hands over your heart and say, schnart.
Schnart.
Thank you. You have all signed the contract. Now continuing. Those of you that don't know are wondering, what is a standardized patient? Well, early in their training, students of healthcare fields, we're not just talking about doctors, we're talking about nurses, physical therapists, naturopaths, acupuncturists, massage therapists, we're talking the whole gamut. In those very, very early days, they go through a very intense period of learning. Basically, they are cast out into the forest of knowledge and left there to just scavenge for information. And during this time, they become like these little feral woodland creatures that are just, stuffing their cheeks full of information, and they kind of cluster together for warmth and safety, and they talk to each other, kind of chittering to each other in their own language. And you can tell they're really young because they haven't grown in their white coats yet. So we are the first non-forest dwellers that they interact with. And that first interaction often looks kind of along the lines of they scurry into the room and they can't really make eye contact, and they say, "Oh, I observe that the patient is in the upright anatomic position, superior and inferior extremities medially adducted in contralateral equivalency." To which most of us would go, "The hell? You could have just said standing." And this is what we are useful for. We rehabilitate them. We teach them, once again, how to speak human. And the way this usually looks, the way this usually goes, is for a class of students, we, in that class session, will all play the same patient. Same symptoms, same history, same diagnosis. Hence, standardized patients. Now, I'm curious how many of you are thinking to yourselves, isn't that like that Seinfeld episode where Kramer was acting for the hospital and he got really angry that he had to have gonorrhea again? It is exactly like that, except without the gonorrhea. That's not true. Sometimes there's gonorrhea. Now, many people wonder what kind of person would choose to be a standardized patient. Well, I'll tell you, it requires a very interesting set of traits. You have to be very empathetic. You have to be able to memorize information and directions very quickly. You have to be very in touch with your body and your emotions. And most importantly, you have got to be able to bullshit. And I am talking professional level bullshit, like put on your waders and bring your shovel level of bullshit. Because when a student looks at you and says, "Oh, it says here in your chart that you have 2 children. What are their names?" And you think in the back of your head, "Shit, I have children?" You can't freeze up and stammer out something like, "Bob and a handhandle." You've got to be confident and natural in your response. Now, because of this, as you can guess, a lot of us are professional communicators, I would say. Teachers, a lot of actors. Admittedly, sometimes the very serious actors, people that are very stage trained and used to a lot of direction, will actually say things along the lines of, "Well, it says here in our case that the patient has a lot of pain when deep breathing. What is our motivation for breathing?" That one was real. So because of this, the people that are really adept at it are improvisers and teachers, because bullshit is a necessary skill when you're working with middle schoolers. For myself, I saw somebody go, "Yes, you're right." For myself, I have been doing improv professionally for almost 25 years. God. I have taught middle schoolers, and I am a lifelong smartass, which means I am exceptionally skilled at this job. One of the challenges, though, is sometimes I have to reel in my natural smartassery. Back a few months ago, I was having an interaction. A girl came into the room and she introduced herself. She said, "Hello, my name is Samira. What is it that you like people to call you?" And before I could stop myself, I said, "Well, I like people to call me sweetheart, but Pat will do for today." That kind of undermines the job I am supposed to do, which is we're supposed to create a realistic feeling simulation, a situation where the students can feel very safe to totally screw up, dare to suck, as a friend of mine would say, without having to worry about a malpractice suit, because it is in failure that we learn. Now, the structure of these simulations typically goes along this pattern. The students come in, they introduce themselves, there's a brief interview asking about our symptoms, about our past history, about our social factors. They do a quick little, some sort of physical exam, and then the students will present some kind of summary talking about what they have observed and maybe giving a diagnosis and a suggestion of treatment. At the end of that, there is a literal and scene. And we will talk to each other, literal, and we will talk to each other as a standardized patient to student, and we'll talk about what worked for us and what didn't. Now remember, for the students, these are very intense, high-stake interactions, and because of that, sometimes it is inadvertently hilarious. They will do things that they would never do in real life if they had their wits about them. And it could be something just very, very simple, like not thinking about what the automatic verbal response they give actually means. One of the ones you see everywhere today is perfect. 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 What brings you in today? I'm bleeding out of my asshole. Perfect. Another one is sometimes a whole string of words will just fall right out of their mouth, and you can see this look on their faces. They get really wide-eyed, like they just threw up on your shoes, and they're trying to play it off like it didn't happen. I had a student, I'm going to call him Timothy. Sweet little, seemingly virginal Timothy. And Timothy was supposed to be doing a nerve exam on the patient to see if the patient, me, had lower spine damage. So Timothy, trying to be all confident, he's sitting across from me, and he reaches over and he drags his hands down the inside of my thighs, and he says, "Have you had any loss of sensation in your erogenous regions?" And I said, no. And he just kind of, and kept going on. He just plowed right through it. When Timothy came back into the room, I just said it straight out. I said, "Timothy, did you say erogenous regions?" And he said, "I know. I was trying to think of another word and I couldn't find my way out." So, a lot of the times, like in Timothy's case, they know exactly what they did. But there's also a lot of times that they don't realize what happened because the words they were using would sound perfectly innocent in any other situation, but in the exam room, it sounds a little off. Another nerve exam that I was having. This one requires you to use a little tool that's rounded on one end and then has a pointy bit on the other end, and you put it up against the skin and to see if the patient can tell the difference between sharp and dull. Well, the young man was preparing me for the test. He was giving me instructions, and he said, "Okay, close your eyes. Now put your hands out. Now you're going to feel a little prick." I told him, "You may want to reconsider that phrasing." And you could see him working to figure it out. He was like, "Oh, no, 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 no." Mortified. And, you know, it's understandable. It's easy to understand how the students forget how to words. Because, like we talked about, they've been living out in the forest of knowledge. Their brains are all full. And on top of that, then they're learning all the things they need to do to maintain the integrity of a health clinic. One of the big things is just washing their hands. Every time the student enters or exits the exam room, they're supposed to wash or sanitize their hands. And it's not just to that end, they have got to stay vigilant on top of it. If a student is taking notes and unknowingly brushes hair out of their face, they've got to wash this hand again. If they, just scratch their nose. Obviously, they've got to wash this hand again. If they drop their pen on the floor, hopefully they leave it on the floor. Ooh, clinic floor. But if they do pick it up, they've got to wash the pen and their hands again. And then on top of that, once you get exam gloves in the picture, it's really intense, because once those gloves are on, they can't touch anything other than the patient and any sanitized tools they're being used for the exam. They cannot touch a counter, a drawer, their seat, a light, themselves, because fact of the matter is, at any given time, any of those things could have been licked by someone. Any of them. One of the most horrible sanitation missteps I had ever seen. I remember this very clearly. This fellow's name was Rami. He was a chiropractic student, and he was polydactyl. He had 2 thumbs fused together. It was so cool. And he was very, very nervous, high stakes exam. It was very cold in the room too. And Rami needed to check my lymph nodes. So he says very properly, he says, "I apologize, my hands are cold. Please allow me to warm them up." And Rami then goes, breathes on his hands, rubs them together, and goes for my neck. And I was just, I didn't even know how to respond. When Rami came back into the room, I was trying to bring it to him gently. I said, "It is really wonderful that you were considerate of the patient and worried about the temperature of your hands for the patient's comfort. Do you know you did that handy, breathy, rubby thing?" And again, he was mortified. First of all, he was so nervous he didn't even know that he did that. And 2, he was not thinking clearly and didn't think about, he could have warmed his hands in warm water in the sink that was an arm's reach away. So the entire interaction wasn't a total wash or hand wash, as it were. At the end of it, I complimented Rami's thumb. I said it was great. It's such a fantastic icebreaker when you are getting to know your patients for the first time. And Rami kind of looks at me sheepishly and says, "You want to touch it?" And I said, "Yeah, I want to touch it," which would be inappropriate in any other situation. But I figure if I get to touch a polydactyl thumb in a very non-creepy manner, I am doing something right. Another way I can tell when I'm doing my job right is when the patients become inadvertently emotionally invested in the simulated interaction. It sneaks up on them. They need to practice learning to give very serious, life-altering information. And when there's a standardized patient in front of them having a very real emotional response, it's not uncommon to see their eyes tear up a little bit in empathy with the patient. I've had students even offer to give me a hug. It's wonderful when they do that. Some students, however, aren't quite sure what to do in that situation. Because remember, like I said, they've been living out in the forest, they got to wash their hands 9 times before they touch anything, and they're so run ragged that who knows if they've even had time or energy to get laid in God knows how long, if ever in their lives. So they have forgotten basic human contact. And you can see, again, the wheels turning, you can see them thinking, okay, this woman is crying in front of me. I should comfort her. All right, her knee is closest to me. I'm going to go for that. Of course, by that point, the moment has passed, but there's cameras in the room watching them, and they know they're getting graded, so they just kind of tentatively reach out a paw. It's like a chameleon going up a branch. It's like that. And then they reach the knee and there's this tap, tap, tap. And by that point, we both know it's completely insincere. So when they come back in for a recap, we sound like 2 people trying to figure out if they should be dating or not. When I touched you, was that weird? That was weird. Wasn't it? Now, Another way that I know when I am doing my job right, and this is kind of one of the cool perks of the job, is sometimes I will accidentally become emotionally invested in the interaction. Those of you that do this job, they can tell you that this is a job that's very easy to take home with you. If you're pretending like you're having a stomach ache all day, chances are that evening you're going to have a little bit of a stomach ache. If you're pretending like you are depressed and have fibromyalgia, I guarantee you on the way home you're going to be picking up French fries and Bengay. This is just the way it works. And in between, sometimes people have to get up and actually shake it off like a wet dog because that energy just clings to you. But as an actor, sometimes it's wonderful when these emotions creep up on you without you expecting it. I was working a training session for some first responders. These were already working, experienced paramedics and fire folks. If I'm the firematics, is that what I heard? Yeah, okay, feromedics. Okay. Now I'm caught up in the world of gender appropriateness. Let's come back. And we just saw mansplaining. I mean, what the hell? So we've got first responders. They're used to it. And the scenario that I had to do was I was the mother of a 3-month-old that was pushing the baby in a stroller going across a parking lot, and a car was coming too fast through the parking lot and hit the stroller. Heavy situation. I knew I was going to have to be very emotionally raw. So I'm trying to think of anything that might open up those sluices of emotion. And I just kept dwelling on, there's an SPCA commercial. And this is before the Sarah McLachlan ones. This is a really old one where there's this little striped orange kitten that's all fluffy, and he's walking down the railroad tracks all by himself. And you don't hear the kitten's voice. You just see him meowing in silence. And then the soundtrack of the commercial is, "What becomes of the broken-hearted?" It's like, I know, it's happening right now. So I'm sitting there and I'm thinking, okay, baby kitten on the tracks, baby kitten on the tracks. And then they bring over to me the fake baby. Now, this isn't just a baby doll. This is a several $1,000 remote control machine. This is some serious action. And they put the baby into my arms. And my first thought is, oh, this is interesting. And then they turn on the baby. I might want to reconsider phrasing that. The baby somehow gains its own gravity, and it starts breathing, and crying noises start coming from inside of it. And that little medium-sized closet of unused maternal instinct that's located right here, the door just fell off the hinges. And next thing I know, my breath is hitching in my chest, and there's tears rolling down my face. And by the time we get going, there's just like snot just coming down and dripping on the mechanical baby. And by the time paramedics are working on the baby, and my eyes are all red and swollen, I can barely see. And then the baby stops crying. The gods of the machine turn off the baby. And I sincerely lost my shit. I was like, oh my God, save my mechanical baby! Which of course, again, sounds like, oh, look at what I did as an actor. But it's not about me. It's not about what I'm doing. This is for the learners. And in this case, a lot of these folks, they've been working in the field. They were very jaded. A lot of these guys were like, why the fuck do we have to do this thing? But the ones that had been in a situation like this, you could see them kind of standing there. Some of them would wipe their eye. Ambulance driver came over and he helped me up off the pavement where I had collapsed. And he walked me over to the passenger door of the ambulance cab and helped me in. And he just sat in the cab with me. Put his hands on the wheel, staring ahead, would occasionally turn and say a word of encouragement, and then just kind of go back and sit there quietly. And as I sat in the passenger seat, giving over to my grief, I thought, jackpot! After the students have gotten through these phases, they've kind of learned how they get all their information in their heads. They've learned how to comport themselves and how to keep things clean. They've learned how to get an emotional response, build an empathetic relationship with their patients. Then they go on to a very interesting part of the incubation process, which is dealing with sensitive information. In particular, touching bodies, ooh, and talking about sex, which, seriously, for real patients in the real world, this is all stuff that is quite hinky, and though important. And in order to lead a patient into this information, the healthcare provider has to be confident, respectful, and non-judgmental. Look at the world we live in. Everything is still very judgmental, particularly about bodies and sex. And nobody, no matter how important it is, nobody wants to answer questions about their sexual history that are asked in a manner that makes them feel shamed and like it's dirty. Some of the students are so awkward with this that they overcompensate and go too far in the investigative direction. And they'll ask questions along the lines of, what sort of sexual practices do you engage in? Penis to vagina? Penis to mouth? Penis to anus? Mouth to anus? Mouth to vagina? Vagina to vagina? Vagina to goat? That's like slut shaming and goat shaming all in one. Look at it, look at me, I'm setting down my invisible clipboard. Oh my goodness. So you know, after those questions like that, you're already very vulnerable. So then when we get to the exam, the last thing people want is to be, pardon the gendered term, manhandled. A lot of times students they'll start shoving your arms into place and moving your legs and reaching down your gown. And a doctor's visit is supposed to feel safe, and that does not sound like safe. That sounds like a first date with a well-known beloved male comedian. Now, thankfully, the students are less on the aggressive side. They tend to be on the other end of the spectrum and things that are a little more squishy. Can I get somebody to help me out in the front row here? All right, come on up. I know Gigi. Everybody say hello, Gigi. Hello, Gigi. Oh, good, you're coming up here, because trying to get back on the stage would be horrible. So, may I have your permission to use you as my guinea pig? Yes. Okay, this is an old joke that I learned many years ago. What starts with "g" and ends with "get off of me"? You've got your line. There it is. All right, everybody. Thank you, Gigi. So, Gigi, that was super creepy, right? See, and that's what happens is sometimes the students are so worried about causing you pain or offending you that they just get those chameleon hands. And that puts you more on edge than if they would just clearly communicate what their needs were in the exam and then get clear consent from the patient to continue forward in the exam. Clear communication and clear consent. Who knew that would make a person feel safe? That's for Jack's show, right? Yeah. Now, once the students have learned to synthesize all these things, their information, how they carry themselves, how to build empathy, how to not be awkward in these situations, this is when you get to see which students are really going to excel in their field. I had an exam, a high-stakes exam, where I was playing a person with an ectopic pregnancy or a tubal pregnancy. This is where the fertilized egg doesn't quite make it to the womb and it just gives up and sits down in the hallway. And this is a very serious situation, and the students had to come in and assess very quickly. And after a full afternoon of a lot of students that were not that bad, and a few students that were, bless your heart. One fellow came in that he just knocked it out of the ballpark. He did such a good job. He came into the room, washed his hands, introduced himself. He was very respectful of my pain level, asked the questions he needed to ask, handled sensitive material very well. In the exam, he used a confident touch, but not to cause me undue pain. He came to the proper conclusion. He gently broke the news to me. He gave me knowledge of all my options. He even got a paper towel and drew a picture to help explain what was going on inside of my body. It was a fantastic interaction. The moment he left the room, you better believe I went to the trash can and got that paper towel out. Yes. This is supposed to be a woman's reproductive system. And somehow what this fellow managed to draw was two skinny penises playing jump rope with a large uncircumcised penis. 3 years into advanced medical training, and these students know nothing about lady parts. But worry not. I am about to introduce you to a fascinating learning opportunity known as the Gynecological Learning Lab. Yes, ladies and gentlemen, not only am I a standardized patient, but I am a model. A gynecological model. I've been told I have a beautiful cervix. And unlike commercial modeling, this is the antithesis of sexy. And it's very important that students have access to people like me with a wealth of patience and a dearth of shame. Because as many folks know, this is a part of medicine that has been overlooked for so long. We are barely a century out of a time where a woman would go to the doctor and the doctor, he would deem her problems hysterical and claim that I'm hearing that that's right, yeah. And then say that all of her problems could be cured with an in-office orgasm. Thank heavens we have backed away from those dark ages. Though I do wish health insurance still covered certain procedures. Now, if you think that talking about sex is terrifying for students, talking while touching sex parts is absolutely panic-inducing. And for fun, I've put together a little amalgamation, a little mashup, as it were, of some of the things that students have really said to me when introducing their first gynecological exam. Hello. We're going to be doing your well woman's exam today. We're going to start with checking your lymph nodes in your neck and in your armpit region. And then we're going to have you lay back on the table and we're going to palpate your breasts to check and see if everything is all right. And then we're going to go to the down part of the exam, which is going to involve me placing a speculum into your vagina, and we're just going to scrape some samples. And then I'm going to use my hands to feel for what's inside, and then we're going to do the vaginal Rectum exam, which involves me putting a finger in your rectum and one in the vagina, and we're gonna just sweep around and make sure everything's all right. Are you ready? Okay, I'm coming inside. I actually had a student say, "I'm coming inside." I have also heard the actual phrases, "Oh, that feels good." I'm going down. I think I'm in you now. And my favorite, there was this girl who was preparing for her exam, and she was trying to get her exam gloves on. Now, sticky hand sanitizer and cheap nitrile gloves don't always go together very well, so she was still really struggling to get on that second glove. And she walked from the head of the table to the business end of the table, and what she was meant to say was, "Oops, my glove isn't on yet, and I walked down to the end of the table too soon." What came out of her mouth was, "Oops, I came prematurely." Now, when trying to help the students figure out how to say what they need to say, I give them a little guideline that if you can say what you're trying to say in a really sultry voice and it doesn't sound smarmy, you're probably on the right track. Compare these two right here. These are two ways to say the same thing. "I'm going to take a good look at your lips." That one feels kind of gross, right? How about, "I'm going to observe and assess the external tissues." Whatever. Okay, here's these two. "I'm going to place a digit in the introitus and check for muscularity." Yeah, I can tell by your silence. You're like, "Yeah." "I'm going to stick a finger in and feel around." That one a practicing doctor said to me. So, verbal aside, once they get into the physical exam, with the breast exam, they usually do pretty well. They understand breasts, they're pretty straightforward. Sometimes you have to... Sometimes you have to say to them, hey, eyes down here. But they typically understand that. It's when you get into the genital exam that they get really, really terrified. Because let's be honest, there's not a lot of opportunities for people to just very neutrally analyze a vagina face to face in person. If you've got your own, it's pretty impossible to vagina gaze on yourself. And if you like them sexually, when you're seeing them recreationally, chances are you're not thinking that clearly. By that point, it's usually just a hot hole with a toggle switch. Which, by the way, is my new euphemism. I'm going to jimmy my toggle switch. Vaginas are terrifying. And I want to introduce you to the realm of some of the things that could potentially go wrong in the internal exam. First of all, the Speculum Exam. Oh, God, I love that sound of people cringing. For the 50% of you, no matter how you present or identify, that have probably had to deal with one of these, hopefully your experience wasn't that bad. A very skilled physician can insert the speculum, open it, get the samples, and remove it with very little resistance in about a minute. Kind of like a hole in one. When you're dealing with people that have never played golf before, there are a lot of water traps and sand traps before you get to the hole. One of the things that might happen is they might scrape your urethra. Now I'm gonna throw some really technical knowledge on y'all here, so see if you can hold on. When the lady is on her backside, all the stretchy baby expelling parts are down toward the butthole. Up above is the pelvic bone, and that don't give none. And then between the vagina and the pelvic bone is the pee tube and the pee hole. Now, a doctor that knows what they're doing will insert the speculum kind of at a little bit of an angle, and they'll put a lot of downward pressure on those stretchy parts so it stays away from all the tender bits up top. Students that are not really thinking about how the anatomy is laid out, they'll think that speculum can just go straight in there, and that front tip will just drag down your urethra. Another point of treachery is when they're actually opening the speculum. And now, once they get it inserted, it's usually not that bad. They know what they're doing. They just got to kind of get it into place. And sometimes it takes them multiple tries, like 2, 3, 4, 5 tries to get it rooted around in there. But once they get it in there, there's not a lot of nerve endings inside. And they should be able to open it up, and the cervix, the little flesh donut that marks the transition from the vagina to the uterus, should just pop right into place. And, that's not that bad. And then to keep it open, sometimes this has this little screw mechanism lock on the side. Sometimes a single pubic hair gets caught in that. Really not that bad, but honestly, a worse thing can happen. I was working at a school that was using these disposable speculums. Now, what makes them different is that they have this little candy cane joint on them, that these little nubbins on the side can move up to the top of the candy cane should you have a woman who's had multiple births or just has more flesh. That way they can have a larger view as they open up the speculum. So I was getting ready for the exam. Student inserted the speculum, but he wasn't paying close attention, and those little nubbins were about halfway between the locked top of the candy cane and the very bottom of it. And when he went to open it, the nubbins slipped. And the flesh of my labia got caught in the joint of the speculum. My minge got caught in the hinge. And seriously, the instructor had to stop everything and untangle me from the speculum. Clearly, I lived through this. I am still doing this job, but I do admit that every time that I hear this sound, I kind of throw into a PTSD style sweat that's only relieved with several deep breaths and maybe a post-lab alcohol. Now, once we're done with the speculums, we get into the bimanual exam. 2 hands, bimanual. One hand is on the inside and one hand is on the outside. Now that inside hand is up against that little flesh donut in there, and the outside hand is trying to feel around for the baby oven and the egg makers. Which makes pregnancy sound like 9 months of cooking a flan. And this usually isn't that painful, but when they're new at it, they'll do little things like a student will have their fingers inserted, and then they'll have a question of the instructor, and they'll just talk for about 5 minutes while leaving their fingers right there inside you. The other thing that might happen is, if you think about how the anatomy is laid out, there's this thumb that doesn't really know where to go. And it's perfectly aligned to touch the one thing you don't want to touch in a clinical exam. Clarification, in a clinical exam. And that is the clitoris or toggle switch, yes. Right there. So, there's supposed to keep their thumb off to the side or keep it tucked in, but you know, they're new at this, they're distracted. So that thumb just starts to naturally drift back in, as nature intended. I decided at one point I was just going to pretend like I was a game of operations. And if they accidentally made contact, I'd just go, to which they jumped. And I get a little treat. Now, bringing up the rear of our exam journey is the Recto-Vaginal Exam. Now, the students, by this point, they really just want it to be over. Pretty much like you are right now. And they're not really looking as well as they should. So they're just trying to like jam their finger into the rectum, but they're not actually at the rectum half the time. They're in that little patch of flesh behind the rectum. Not the taint, but the taint that neither. And they're just jamming and jabbing and jabbing. And this is the thing that really hurts. And so I have to tell them, I was like, stop. Just take a deep breath and remember, assholes are like opinions. Everybody's got them. And sometimes you have to really look at them and gently work your way inside them to truly understand them. I never get tired of doing that. Mom, it's just my rectal finger. So there was a lab I was working at one of the schools where they had to take a labial tissue sample. That's just as fun as it sounds. They were scooping a little chunk out of my junk. And the student that I had for this lab was a hot mess from the start. The moment he entered the room, he was just flop sweating. And when he got on his gloves, he was just touching everything and wiping away his sweat, and he's literally dripping on me. And he was supposed to give me a shot of lidocaine, a deadening agent, to numb the area where the sample was going to be taken from. So he's sitting on the stool. He's face to place with me, holding open my little ghibli bits, and as much as I don't look forward to the idea of a needle getting stuck in those tender bits, he was 10 times more terrified. So he's just sitting there like trying to work up the bravery, just... And finally the instructor just spoke up and said, look, you've got to do this. Just take a deep breath, tell the patient what you're going to do, and then insert the syringe. So he gears himself up. He gets ready, he looks me in the eye and he says, okay, you're going to feel a little prick. To which I said, no, you can't say that. Don't make any promises you can't keep. After all this, you're probably wondering why I still do this job. Well, I'll tell you this. Number one, you gotta earn a paycheck somehow, and they give you $10 extra if they go in your butt. Number two, I find this work very, very satisfying. Some of the best acting I have ever done in my life was for an audience of one. And the students consistently tell us that, that these are some of the most valuable experiences of their training. 3, I have very strong opinions about doctor-patient interactions. And here's why. I was on the Gravitron when I first noticed something was different. I was 25 years old. It was September in coastal Texas. I had just moved back to my hometown of Lake Jackson from Austin after losing my primary job. Ask me later why I'm a do not rehire at Starbucks. And I was taking my then 13-year-old sister and her best buddy to the county fair. We rode the rides. We went on the swings, we went on the super spider, we went on the rock and roller, and my favorite ride, though, is the Gravitron, which is just basically a giant centrifuge with safety padding on the inside. So we're on the Gravitron, I'm plastered up against the padding, and I noticed this weird pressure in my chest. It was like something was kind of pulling up and back towards my shoulder blade. And my first thought was, do I have a chest cold and I don't know it? When I got off the ride, the sensation was gone, so I just tucked away that little moment in the back of my head. About a week later, I had developed a cough. It wasn't producing anything, it was just this dry cough that would sneak up on me. At the work where I was waiting tables every day, customers would say to me, "Hey, are you a smoker? No, maybe you should start." And I never smoked before, so I was like, yeah, maybe I should. A few days later, I decided that I should probably go see the family doctor. His name was Dr. Trenton. He was a stern man in his mid-60s, and his office was packed. The waiting room lived up to its name that day, and I was lucky to actually get in to see him. By the time I actually got to him, I explained what was going on. He listened to my breathing at 2 points at the top of my back, and he said, "Well, there's no need for a chest x-ray." Convinced me it wasn't worth the money, and I was young and underemployed, so I agreed with him. He wrote me a prescription, sent me out the door. About a month later, the cough had gotten significantly worse. It was much deeper, and I was actually feeling sick. So I managed to go in to see Dr. Trenton again. And in that visit, which was under 10 minutes, he never once touched me. He never asked me any questions. He didn't listen to my breathing. He just wrote me a prescription and sent me back out the door. November rolled around, and I lost my taste for food. I lost my desire to eat. And because I had been told all my life that I was too fat, I thought it was a little bit of a blessing to be dropping a few pounds. So I just accepted it for what it was. By late December, I knew I needed to go see Dr. Trenton again. When I went in, he said, "Well, there's a flu going around. This could explain why your cough's so bad. This could explain why you're occasionally running fever. This could explain why you're tired." Wrote me another prescription, sent me out the door. At the top of January, I had landed a job teaching middle school theater at the local intermediate school, and I was barely making it through my work days. By that point, I dropped about 30 pounds. I was sleeping at least 12 hours a day. I was constantly running a low-grade fever, and I was having coughing fits so violent that I would either nearly pass out or I would actually throw up from coughing at least twice a day. Mostly I was just exhausted because I had no idea what was wrong with me. A coworker said, "Maybe it's pneumonia." And when I saw that the local drug study clinic was looking for pneumonia patients, I went to go check it out. I went to the drug study clinic. That doctor, Dr. Spivey, was fantastic. He asked me questions. He listened to my heart. He listened to my breathing on all the points in my back and my chest. Dr. Spivey said, "Well, I think you're eligible for this study because there's actually no airflow in that lower left lung. Let's send you to the hospital and get your images taken." So I go to the hospital. They take an x-ray. They call me back in for a second x-ray. I figured they messed up the first one. It was taking a while before they sent me back to the drug study office. And when they did, Dr. Spivey had me sit down in his office and he said, "Well, I'm afraid you're not eligible for the pneumonia study because there's no evidence of pneumonia. But there is a shadow, and we're going to send you to your primary doctor immediately." They made the arrangements. I went to the office. Dr. Trenton saw me immediately. He spoke to me for the first time as an intelligent human being and not an hysterical 25-year-old girl. He spoke of future appointments. He spoke of referrals. He had no hard answers. But I didn't need the hard answers. I actually had a little bit of relief because I finally had a name for what was going on. I knew at the moment they said there is a shadow. It was cancer. I had Hodgkin's disease, and it manifested as a tumor that took up 2/3 of my left lung. Had I gone another couple of months without diagnosis, it's very possible that I would have suffocated on my own body. I went through 6 months of chemotherapy. It didn't take. The tumor started growing again. I went through another more intense round of chemotherapy, and then I had a stem cell transplant. I rang in the new millennium, a hairless monkey in a hermetically sealed room watching South Park episodes and TV evangelist Pastor Rod Parson. When I got out, I had some rounds of radiation. I had my final treatment on my 27th birthday. And 5 years after that, I was told that I was clear of the Hodgkin's. Now, I still say that that year of the cancer was the most important thing that happened to me in my life. I gained a lot of experience and knowledge, and it really did help form who I am today. But I also lost a lot because of the cancer. I lost the opportunity to see my teaching career begin. Although admittedly, using cancer as an excuse to stop teaching middle school was the best excuse ever. I lost my ability to work long hours. I get tired really easily. I lost my immunity. I catch at least 4 colds or flu a year. I lost my ability to have children, and therefore lost my opportunity to ever have a normal relationship. And mostly, I lost the confidence to ever not think that every pain that I feel, every symptom that I see, is the cancer coming back to get me. And I just speak honestly when I say that as I see all the people around me getting married and having babies and advancing in their careers and buying houses and saving for retirement and going on vacations and eating food and just fucking breathing, I feel like a burdensome boondoggle on society just ticking off undeserved and unexpected time. And I honestly think that almost all of that could have been avoided had one man really listened to me and taken a chest x-ray instead of trying to save a buck. This is why I am a standardized patient. This is why I want to help the next generation of healthcare practitioners learn to truly communicate and how to treat their patients, not as a puzzle, but as a person. And I will preach to the mountains, or at least the neighboring bar, that I think it is a fucking shame that we live in a country where one bad turn in the hospital can drive a family bankrupt, and that we need GoFundMe pages to keep people alive. I had a doctor from here in town, a fantastic doctor, that she closed up shop and moved to Canada because the insurance companies were keeping her from doing the one thing she wanted to do, which is heal people. And there is absolutely no reason why we should not be able to collectively put our energies together so that everybody in this country has health care. But the reason we are not is because your illnesses are being treated as a cash crop. And if that kind of talk makes me sound like a socialist, then fuck it, call me a socialist.
Amen. Exactly right. Preach.
But you know, I can preach all I want to, but the truth of the matter is, it's not going to change anytime soon. Not soon, but it is changing. In the past 8 years that I've been doing this work, I've gone from students looking at me with a look in their eyes like, you want me to do what? To actually speaking with me afterwards saying, I felt like we had a really good connection in that interaction. What can I do to help you feel more supported as a patient? One of the schools I work at is developing a metric to test students on medical ethics and use of patient empathy. And that is possible because of standardized patients like me. And I am proud to be a part of that change, even if it means me having gonorrhea. Again. Thank you. Thank you. Thank you very much. Thank you. I have a few final announcements I would like to make. First of all, I want to thank the Clinton Street Theater for allowing us to have this show here. I want to give a big thank you to Jason Potter for moving this all into action and his fabulous camera crew that has come out here to film this. I need to give a big thank you to a friend of mine, Jacob Moorhead, that helped me shape this show. A huge thank you to Jaguar Bennett for coming up from Fresno and helping us out. A little shout out to Patrick Short at Comedy Sports for loaning me this microphone. And again, just all of you for being here. I cannot thank you enough.